Dr. Meyer, please.
Ladies and gentlemen, dear Pam, dear Professor Dengler, it's a pleasure and also a great honor to highlight the clinical sessions of this year's symposium. And as you said, I regard myself as a clinician, and more specifically I'm interested in trials and more recently also in internet applications in home care. And against this background, I have to admit that there may be some selection bias in my presentation, and I'm sorry for that. Anyway, let me begin with some really objective data. And the clinical sessions included 47 oral presentations on clinical issues as compared to 49 talks on basic science issues. Among the clinical sessions, I have identified three main topics. Topic 1 was on management and care. Topic 2 was on trials. And topic 3 was on phenotypes, disease progression, and diagnostics. From the total number of the papers, I made a small selection as shown in this slide here. The program committee selected from several countries papers with first and last authors from 13 countries in total. More specifically, there were 17 presentations from the United States, 7 papers from the United Kingdom, and 4 papers each from Germany, the Netherlands, Italy, and Spain. It struck me that it was just 1 paper from China and only another paper from Japan. And what is even more striking, that there was not a single presentation from the African continent, no paper from Latin America, no paper from Eastern Europe and Russia. I believe that in the next few years we have to do something about that. Clinical trials that you see here in green in this slide was a domain of the United States. All 6 presentations had US authorship. On the contrast, there was not a single paper from the US on palliative care. That seemed to be talking about the oral presentations, a domain of UK, of Germany, and Japan. Another remarkable observation was the low number of multinational contributions. There was just 1 paper with co-authorship of clinicians from the UK and Australia, and there were 2 papers in an American-French connection. Apparently, there's a great potential for future multinational, and by that means also transnational projects in the clinical part of ALS research. This year's symposium helped a great deal to translate evidence from clinical studies into the clinical practice. And Robert Miller and co-workers from San Francisco, he systematically studied evidence on ALS management. They showed that our effort in specialized teams is apparently justified, and I think it's a good news for all of us that we are apparently doing a meaningful job. There are several Class 2 and Class 3 studies demonstrating that multidisciplinary centers help to increase the use of adaptive equipment, the use of aerosol PAC, non-invasive ventilation, and improve quality of life and extend survival. More specifically, there is Class 2 evidence for PAC. There is Class 1 evidence for the effectiveness of mask ventilation. And there is Class 3 evidence only for mechanical ventilation, preserving quality of life, but at the same time, tracheotomy may be associated with an increased burden for caregivers. there is conflicting data on the survival issue. Even in this symposium, there are 2 papers from one country, 2 papers from Italy, showing diverse results. One study showed a survival of 40 months, another study from the same country of just 9 months survival. Beyond the established treatment options, at this year's symposium, we have learned more about novel treatment options. In 2 papers, the current state of diaphragm pacing was reported. Ray Unmus of Cleveland, he presented the results of a prospective, non-randomized but controlled trial on 106 implantations and a 9-month post-implantation treatment period. And he showed that the slope of decline of the forced vital capacity was 1.6% per month post-implantation as compared to 2.7 during the lead-in period. There are some limitations of this study, mainly due to the open and non-randomized design and the lack of sham stimulation. The benefit of non-invasive ventilation is well established, but a major problem is the muffling of the voice because of the mask and the associated air flow. And to overcome this problem, Dr. Chua of Vancouver, working with Andrew Eisen, he suspended a tiny microphone near the top of the mask, and he amplified using a sound output system the patient's voice, and the result is that the airflow noise was removed and the patient's voice became more clearly. Away from technology-based improvements, Bea Goldmann of St. Gallen, working with Markus Weber, she addressed the enormous demand of information of the patients and the caregivers, and also of professionals that cannot fulfill, as you all know, during the regular consultations. And therefore they designed a training program consisting of 5 modules lasting 5 hours on 5 different afternoons. And the modules were, as you see here, on mobility, on ventilation, on nutrition, home care, and end of life. At this training participated more than 40 patients, more than 50 caregivers, and more than 20 professionals. And the outcome of this training program was measured in a way with a post-training questionnaire leading to a kind of knowledge score. What you see here in this table is the absolute change of the post-training knowledge, showing that actually the knowledge was increased in all modules by all participants. And this study shows that this training program may be an effective way of transferring knowledge in ALS home care.